चौथा जी, इसके लिए कॉम्प्लीमेंट आपको मुझे देना पड़ेगा क्योंकि आई एम ब्रिंगिंग ऑल द स्पेशलिस्ट.
Yes, all these specialists who come, all of them. I think there was one who said that he was born in 1985. And by then, we had been working for quite a long time ourselves.
Yeah. So it's really a proud moment to be a part of this very great initiative by Indian Cancer Society, and of course, thankful to Shrenik Bhai,
Yes, absolutely.
opportunity.
We couldn't do it without him.
So we have started with a YouTube live now.
Okay, great.
Wonderful. Great, great.
I
Chota ji,
introduced Ritika Bhavdeep.
Ma'am, we have already done a short introduction of Ritika
Oh,
and अभी फिर हम लोग सेशन स्टार्ट कर रहे हैं.
हाँ, बिल्कुल start करिएगा.
जी मैम.
all right. So, good evening, friends. Uh, this is Shrenik from Ahmedabad, and well, I am stage 4 vocal cord cancer survivor, currently in my 28th year, and I am having every time, every Friday, I am having a fascinating moment to moderate the live session by inviting expert speakers from all over India. And see, we at Indian Cancer Society always believe in innovation. The reason I am using the word innovation because until now we have brought surgical oncologists, radiation oncologists, clinical medical oncologists, but today we are having a commendable down to earth and radiologist. She is wearing smile every time whenever you see her, and I would like to introduce her in a bit different manner. You know, we are using the digital payment system every now and then, and whenever you do effective payment, this system says that scan the QR code. That means you need a camera to scan the QR code. Today, our esteemed guest, Dr. Diva Madam, she is like a camera, she is like a conducting a scan of MRI, PET scan, USG, and whatnot. And let me tell one more thing that all oncologists, surgical, radiation, medical, and including clinical oncologists, they greatly rely upon reporting done by the radiologists. So today is our 20th session back to back. I am fortunate that to mention that this is our kind of our marathon at ICS Delhi, that we are doing back to back session every Friday, and without wasting much of the time, I would like to welcome Dr. Diva Shah. I mean, she has been into this medical profession for more than 20 years, and especially in the field of oncology as a radiologist, and our reports are considered as a most reliable and trustworthy. And on the other hand, I mean, she is a multifaceted personality. She has delivered over 100 drugs all over India and abroad. She has given a lot of presentations and so on. So, Dr. Diva Madam, welcome on board, and stage is all yours. And I mean, we are looking forward to listening to you. Thank you.
Thank you. Thank you so much for such a kind words, Shrenik Bhai. First of all, to begin with, I would like to sincerely thank Shrenik Bhai and the Indian Cancer Society entire team for this wonderful opportunity. I'm not a good photographer, let me tell you, but yes, I wish to be a very good imaging specialist and wishing to work more for the cancer patients and wishing to work more with prevention, how we can detect early cancers. And let me tell you first, before I begin my brief talk on what is the role of radiologist, Shrenik Bhai is truly an inspiration to entire cancer society, and it's a source of pride for all of us, especially for me, being associated with him since last 10 years. And it's a great feeling that I'm a part of this Friday sessions together. So shortly, I'll share my screen with you. Yeah. Yes. Can you see my uh, presentation here?
Yes.
Yes.
All right. So myself, Dr. Diva, I am a lead consultant radiologist, currently working hybrid imaging and oncoradiology department of Gujarat Imaging Center, Ahmedabad. And I'll be talking on navigating across cancer care. What is the role of radiologist in the journey of cancer? So we'll start with, if we talk about any disease, whether it's a cancer or anything which happens, so basically cancer care is the multidisciplinary care nowadays. So what you look, it's just a tip of iceberg, if I can say. So to know the true extent of the disease, to know what is happening in the body, multiple doctors, great team is involved in this. So basically, it has radiologist, pathologist, geneticist, intensivist, physicians. So basically, it's a teamwork to know, to categorize the disease, to give the best treatment to the patient, and mainly to prevent the disease. So this is how the radiologist or the oncoradiologist are the part of the cancer care. If you look at the current scenario of cancer in India, definitely it is increasing over the years. Most common cancer that we see in females are the cervical cancer and the breast cancer in India, while in males it is lung and head and neck cancers. So these are the four which are the most common cancer which we see in India in our day-to-day practices. Now, before I dwell into the how the radiologist helps, this is one which I think many of us know, many of us which who are not knowing NCCN. It's like National Comprehensive Cancer Network, which has the web. This is the website which gives lot of information about each and every cancer. It has given the patient's guideline what you can get the information you can get. So please go through this site whenever you are suffering or you have any questions about, because cancer is the world. So don't get lost. Ask the questions to your physicians, to your known surgeons, and then get through into it. Cancer is never cancelled. So, if we talk about the current scenario, how the radiologist is a part of this process. So, let me tell you, the role of radiologist not begins when you are having cancer or when you are suffering from some symptoms. The role of radiologist begins before you get the symptoms, and that is screening. So, what is screening? Is when you don't have any symptoms, you are just doing your routine checkups of the body, and you are knowing what is happening inside your body. So that's the screening process. So I'll discuss about these four parameters one by one. where radiologist is helpful. So coming with the screening first. So screening means we know that early detection is best prevention. So early detection and prevention of the disease is crucial in fight against the cancer, especially sorry, especially in the people at high risk of developing malignancies. So there are many ways of the where radiologist is able to identify very early signs of an individual developing cancers. So we should also have the awareness of various cancer screening program which happens in India, and its implementation is very crucial in this developing countries. So currently these are the four main cancer screening program which is going on, and this is how we can detect the cancer before it shows the signs and symptoms of the cancers. So first we'll begin with the lung cancer screening. So what is the first question which comes in our mind? That every person should undergo this cancer screening or not? So your answer is here that lung cancer screening is not recommended for everyone. Screening is basically recommended for those who are at risk for developing the lung cancer. So you should always consult your healthcare provider and whether are you qualifying for the lung cancer screening or not. So what are the risk factors that is related that you should, yes, you should undergo lung cancer screening by a radiologist. So if you are a tobacco user, if you have a radiation exposure, if your occupation is exposure to the asbestos or any chemical agents which causes cancer, if you have a previous cancer history, family history of lung cancer with first degree, if you have a chronic obstructive pulmonary disease, or if you have a fibrosis, if you have secondhand smoke exposure. So these are the risk factors. Now how do we do screening of the lung cancers? So first we do is with low ultra dose low CT scan. Now we know about the CT scan machine, which is a large tunnel in the end. It has a tunnel in the midline. It uses the ionizing radiation. Now what is this low dose CT scan? So this is a very good thing that let me explain you the CT scan which has a ionizing radiation which has some potential hazardous effect to our body. Usually on one CT scan we get 7 millisievert radiation, but this ultra low dose load which reduces the radiation of 1/5 than the routine CT scan, and here it uses the small amount of radiation, and that is why we uses this for the screening purpose, that in the high risk patient. And what do we see? We see basically multiple nodules in the lung, or whether there is nodule which looks suspicious for cancerous, then we undergo more into it. So this is how we do a screening of the lung. Next and most important is breast screening. We know that breast cancer screening saves the life. It detects the cancer very earlier, and when it can be treated more successfully. So more early the stage, we know more good prognosis of any cancer. So breast cancer screening program runs all throughout and in each and every states. So always we should take part in this screening program. So now the next question comes, should I undergo screening? Or at what age I should? This is a very common question which I come across during my practice. So basically, when we should evaluate. So American Cancer Society has given a specific guideline, and this is how we follow. So the woman who wants to undergo the screening program, it can be divided into average risk and the high risk. So what are the factors that we see? If a woman has any personal history of breast cancer or not, any family history, first degree relative has breast cancer or not, any genetic susceptibility to breast cancer or the subset of the cancer, if she has history of she is not she is unmarried. So these are the various risk factors that we consider first. So before we go into the high risk, first we should aware of what is the average risk. Means the woman who is not at high risk, she also should undergo this routine screening mammogram. So she should start at the age of 45, and she should do the mammogram every year. I'll come to the what is mammogram in the next slide. between the 40 to 44, woman has option. Either she can start the screening with her choice, or she can go only sonography of the breast. While woman who is more than 55, she can switch to mammogram every another year, or she can choose to continue yearly. So this is the guideline for the women who are not at high risk. Now, as I discussed, what is the high risk woman? So first degree relative with family history, whether it's a mother, sister, so she has history of that strong family history, or she is BRCA1 2 gene mutations positive, or first degree relative has this positive genetic mutant. The other histories can be if she has a history of radiation therapy to chest wall between 10-year or 30-year-old. So these are the risk factors. Apart from it, if a woman has not breastfed any time ever in the lifetime, if she is unmarried, so these are the certainly high risk factors. Now there is a specific and a different guideline for the patients who are high risk, the females who are at high risk. So for the screening, it starts at the age of 20 plus. So that guideline is self-examination and the clinical examination, while her mammogram should start annually at 40 years of age. And if she is high risk, it starts at the age of 30 plus. And the screening cannot just be with mammography, it can be with MRI, magnetic resonance imaging. So the same question again, I'm going how we should do, how the radiologist helps. Apart from self-breast examination and clinical examination, what imaging modality we uses to detect the cancer, to detect what is happening in the breast mammogram. So it is screening mammogram. As I said, screening is before the symptoms happen. The symptoms we know well, that whether there is any lump or any nipple discharge, or you have any asymmetry in the breast. Occasionally you may have pain or any lumpish feeling in your underarms. So these are the symptoms, and the woman should undergo this mammograms. There are other modalities also which we uses for detection, and there are the complementary modality like ultrasound, magnetic resonance imaging, and PET CT scans are the advanced modality for not just screening purpose, but for the staging of breast cancers. So this is the mammogram, how we do, how we perform in a patients in a routine screening procedures also, and in a patients who have suspected breast cancer. So basically, it's a very low dose ionizing soft radiation uses, and there is a compression pedal. Here we image the breast tissue, it get compressed, and we see the details what is happening inside the breast. As I said, breast MRI is indicated as screening in a high risk female. So this magnetic resonance imaging test that uses the magnetic field and the radio waves to create the images. Here you can see the schematic diagram. That is how patient undergoes for evaluation of the breast MRI, and it is recommended in high risk patient for screening. Otherwise, it is recommended in a patients who have already diagnosed breast cancer, and we are suspecting the spread of the to evaluate the extent of the breast cancer. So these are the certainly different imaging techniques. The pictures here you can see, this is the mammogram, this is the ultrasound which uses the sono wave, and this is how we detect the tumor inside the breast. This is the MRI, and this is the FDG PET CT scan. Next is colorectal cancer screening. So again, there are guidelines, specific guidelines that who should undergo this colorectal cancer screening. So it is average risk versus increased risk. Average risk means there is no history of any colorectal cancer, or first degree relative who have previous history of polyposis within the bowel, within the intestine, or if you have any this kind of symptoms or syndromes, if you have a history of colorectal cancer in your family, if you are suffering from inflammatory bowel disease, if you are suffering from familial genetic syndromes which has been given, this is the list of the syndrome, then these are the high risk patient, they should undergo screening. So how we as a radiologist help as a part of this cancer screening? So it is CT colonography. So here we uses the machine CT scan, and we examine the entire colon and we detect small polyps, adenomas, or if there are any cancers which is seen on CT scan. Even apart from CT scan, MRI has also a role in evaluation and staging of the colorectal cancers. So this is how we detect apart from colonoscopy. So if you have any symptoms regarding your bowel, if you have a bleeding per rectum, if you have any often on diarrhea or constipations, so these are the some of the symptoms, then you should consult your healthcare provider, your physician. And this is how we do the analysis of the bowel pathology or intestinal pathology. Cervical screening is again another screening program, and as such there is no direct role of the radiologist in the screening process, but definitely radiologist has a role in evaluations of the various gynecological cancers, cervical cancers, and evaluation what is happening inside the cervix and uterus and the various organs. So the screening guideline which has been given, that is between the age groups, that is the PEP test which has been done every 3 years, and for 30 to 65 it has been recommended that PEP test with HPV contesting every 5 years, and more than 65 there is no screening following adequate negative testing. But how the radiologist helps? So as I say that radiologist help, so we have a basically three modalities, and this is how we see. So first and foremost is ultrasound sonography, which is very easily available. So we see the internal organs, we see what is happening with the endometrial lining. We can clearly see the endometrial lining on ultrasound, what is happening with the ovaries. If there is any lesion tumor within the cervix, we can see. We can see the various sizes and the morphology of ovarian cyst. The next investigations which is important, where we see the staging of the tumors, that is MRI. So here you can see, this is the picture of the MRI. This is how we image the uterus and the entire pelvic organs. And if anything happening, if anything small 5 millimeter size polyp also, we can evaluate with the help of MRI, and we stage the tumor with the help of MRI. Next important thing which I would like to say is detection. How the radiologist help in detection of in a known cancer, in a known patients. So basically we uses various medical imaging modalities in detection of cancer. Second thing is important skill and experience of the radiologist. We uses various advancement in the technique. And the next is structured reporting, how we form our report after the analysis of that particular modality. So if we say the detection, what are the various modalities we uses for staging or evaluation of the cancer? So currently we have these four modalities available, that is ultrasound, sonography, CT scan, MRI, and PET CT scan. To avoid the unnecessary invasive procedure, a comparison of various images through different method, it is the first step towards a diagnosis of any cancer. And definitely whenever needed, we also do USG, that is ultrasound, or CT guided biopsy, that is we put the needle inside the and then we take out the tissue. So in a nutshell, we are the radiologist, we are the first person to detect the tumor based on either clear symptoms or a clinical finding or previous suspicion. A critical part of cancer imaging is assessment of whether the abnormality reflect the cancer, or whether the whatever abnormality we are describing that is relevant to management of the patient. This is the most critical part in our reporting format, that we have to see where the skill and experience of the radiologist matters most. That whatever abnormality we are telling to the clinician, it should be helpful, it should be comprehend to the patient. So how we do it? So we follow certain rules. So let me just tell you about these rules. As we know that cancer grows like cities radially until they meet a physical barrier. So they grow radially, and which they spread along are or given a road to follow. So let me show you this image of an ovarian cancer here. So they go radially, they spread here into the upper part of the abdomen also, and they crosses the physical barrier inside the body also, and then they spread into the other organs also. So this is the first rule that we follow when we are detecting the cancer. Second rule, just as we know that children generally resembles their parents, when you have a cancer in any part, that you, if you are, for example, if you are suffering from the thyroid cancer, or if you are suffering from laryngeal cancer, if you have a uterine cancer, and then somebody, we say that you have a spread into the other organ, so that is known as metastasis, spread to the other organ. So that metastasis, uh, imaging wise, it resembles to the primary tumor. So there is a significant resemblance to the characteristic of the primary lesion and the metastasis. So here I have taken the images of the sonography of a young gentleman who came to us with fullness in the neck. There was a fullness, there was a swelling in the neck. So we did the sonography and we found, yes, there is a tumor in the left lobe of thyroid. There was a tumor in the thyroid gland. So when we go deep inside, yes, there is a metastasis in the node also. We have a multiple normally nodes in the neck, but that nodes was abnormal. And we did the CT scan. So if you see here, both the pictures are looking same. So this is why there is a resemblance of the tumor and its spread. So this is a second rule of diagnosing the spread into the known cancer patient. The third rule that we follow as a security agency, we have learned, if members of the crowd behaving differently from rest of the crowd, they are probably not a part of it or need to be watched. So here I'm making a very important point that all the whenever we are doing the CT scan, MRI of any known cancer patient, if we see any tumor, or if we see, it's not like that this is all spread, patient has undergone into the fourth stage, third stage. So we have to characterize this different tumors very meticulously, and we have to see the characteristic of each spread, that what is happening. For example, this is again a patient of a thyroid nodule. Patient came, yes, there was a nodule in right lobe of thyroid, but there were other small nodes in the vicinity of right lobe of thyroid. So it doesn't mean that this is both. Now if you see here, rule 2, as per rule 2, both are looking different. One is hyperechoic, one is hypoechoic, as per our terminology of sonography. And we did the CT scan here, and no, this is different than this. And then the biopsy was done, and this is not a cancer. It turned out to be a tuberculosis, which is an infection, which can be treated very well with the anti-tubercular drugs. So this is not cancer. So these three rules are very important as a radiologist to evaluate any cancer. We uses various recent advances. We know that medical field is full of advances. There are lots and lots of technique which every day is evolving, in not in medical field, it is in science. So all this new technique, new advances help us to becoming us better and better. We evaluate the cancer in a better way. We stage the cancer in a better way. So this is the perfusion scan we uses basically for various head and neck cancers, where we see the blood flow and the analysis of various tumors. We also uses diffusion weighted imaging for what is happening, what is the cellularity of the tumor. We uses the CT scan. Here is an example of a laryngeal tumor. Shrenik bhai knows, I think now more than me, for various laryngeal tumors, I must say. So basically here, this is a laryngeal tumor, large bulky tumor. We image this thing on MRI or on CT scan. What is happening, whether when we evaluate the laryngeal cancer, we need to see that what is the extent of that cancer, whether whether the surgeon needs to remove the entire voice box, the laryngeal box, or he can preserve it. This is a very crucial point, definitely in the treatment of for the laryngeal cancer. And we stage this laryngeal cancer with the help of this advanced technique, MRI, diffusion weighted MRI. PET CT scan is the gold standard for evaluation of advanced cancers, or there are various different stressors now in market available for evaluation of different kind of stressors. We also do the fusion of two modalities, like nowadays fusion is, I think, available. We are seeing hybrid terminology in lot of things. So in medical science, we see this is a hybrid fruit or hybrid vegetables with the technique. So same way, the hybrid modality where we take the advantage of the two different modalities. So here there is a fusion of the PET CT scan and MRI in a patient with the head and neck buccal cancer. When we have a doubt of, yes, patient has spread into the skull base or along the nose, where surgery differs, the total treatment options differs. So this is how we uses the advanced technique. Next stage comes after the screening, after the detection. Next comes how we form our report. What is important in our report? So the important thing is say what you mean and mean what you say. We know this. So what is the importance of the report of a radiologist? So this is, I can give you this example of a, if I'm doing the staging of a lung cancer, if I prepared the report of the staging of a lung cancer, so that report goes to so many people, so many different subsets, and it should be readable, it should have a proper interpretation, and most importantly, it should guide the clinician that what should be done next in this patient. So the it goes to the patient, it can goes to the family doctor, to the treating surgeon, to the pathologist. It also goes to the palliative care physician in a advanced patients where the chemotherapy and palliative therapy are going on. It also goes to the radiation medical oncologist, where we discusses. So basically we are the center of this multidisciplinary team, where the report is being discussed with all different subspecialty, and this is how the combined decision is being taken to that particular patient, that what is the best treatment strategy we can offer to the patient who is suffering from particular cancer. And after this treatment, it also goes to the cancer registry, and this is also where the documentation and the evidences of each patient being done, and the information of the cancer patient being kept. So this is what. Next comes the staging, how we helps in staging and evaluation as a radiologist for various cancer. We know that accurate and preoperative staging is heart of any cancer, and it is widely based on imaging and the pathological finding. So to answer the different question, radiologists can use all modality techniques. We have to understand that there is no single perfect examination, but combination of examinations is appropriate strategy, even if CT scan is the usual starting point. So there's not a particular modality which is important. We, as there are n number of cancers, each cancer has different varieties. Same way, there's not just a single modality which can detect any and all type of cancer. So it depends on what kind of cancer we are looking for, what kind of stage we are looking for. There are multiple factors we have to keep it in our mind. Let me give you a one simple example. This was a lady came with the right breast cancer. So this is the FDG PET CT scan, where you can see the large tumor in the right breast. There was a spread into the axillary node also, and even the mediastinal node also. Now, surprisingly, she has this similar light bulb looking avid lesion in the kidneys also. Now, if we see here that these two things, then patient underwent into the stage 4. So is it a metastasis or it is something else? So all this is what is this interpretation is very crucial in deciding the treatment strategy. So in this patient, the ultrasound guided biopsy and the mediastinal guided biopsy was done from this node and this kidney lesion also. So this is how we perform the ultrasound guided biopsy, that the biopsy is done. This is how. And then the pathologists read this entire report, that what is happening inside the, so what is the analysis being done. And in this patient, this was turned out to be amyloidosis, which is not a cancer. So this is how the patient entire stage has been changed from stage 4 to stage 2. And this is how patient was being operated for right breast lesion, and now she is fine. So this is how the we take a multidisciplinary decisions. This is how we image each and every patient, that all the tumors which shows FDG uptake not necessary, they are metastatic. So interpretation is very crucial and very important to decide the staging. The next role of the radiologist comes in therapy and treatment planning. So, whenever a patient is detected with the cancer, various cancers, either following the surgery or following any chemotherapy, we assess what is happening, what is the response. The tumor response assessment is again a next important and integral part of a radiologist. So there are various response evaluation criteria that we uses with various modality. Most important is RESIST, that is response evaluation criteria in solid tumors. And second is PERSIST, that is PET response. If a patient has underwent a PET CT scan, then we do the response with the PET response criteria. For example, this is a tumor. Here you can see a large tumor. This is a large gastrointestinal stromal tumor. And here you can see this is a pre-treatment scan and this is a post-treatment scan. So this is how we compare image to image. We also compare whether the FDG avidity has decreased or not. And this is how we help in evaluation of the tumor and its spread, that patient is responding to the chemotherapy or immunotherapy or not. So this is how we are the radiologist image the various tumor and response evaluation. Next, I would like to just tell about the future of cancer imaging. So as I previously in my previous slide, I talked about it begins with the screening, that before the symptoms develops. In a future, near future, it would be more with the with the advent of the various molecular marker. The diagnostic will it will change the paradigm of the radiologist and the diagnosis. It will be more of a molecular diagnostics. There will be molecular imaging and functional whole body imaging, which will be added into the evaluation and the diagnosis, staging and treatment monitoring and the disease progression. To conclude my talk, so role of radiologist, which begins here, this is a pictorial review of the entire journey of a patient. So it begins with the screening when the patient has a family history. So this is a mammogram, and then we detect a tumor. The after the suspicion of the tumor, we go with the ultrasound guided biopsy or CT scan whenever needed. Then next comes the staging with the help of CT scan or PET CT scan. And then this patient, we do a follow-up that what is happening, whether if, the operative bedside is normal or not, is there any spread. And in this, there was a development of a small metastatic lesion in the liver. And then since it was a solitary lesion, it again got operated. So this is a follow-up imaging. So basically, it begins with the screening and then detection, then the staging, then following staging, following treatment. It is a response evaluation or post-treatment scanning, which happens at the interval. It is recommended as per the recommended criteria, as per the NCCN guidelines. We follow the NCCN guideline. And if there is any recurrence, then again, we do the biopsy or the restaging of that particular tumor and then the follow-up scan. So, in summary, the landscape of radiology is shifting very fast. Technological advancement are pushing the boundaries of what we thought possible. So, going hand in hand with the other branches of science, radiology has also evolved, offer better solutions, and bringing new rays of hope for the cancer patients. Thank you so much. We can take the questions now.
Uh, Dr. Diva, madam, thank you. Friends, I would like to add 2 points here. You know, after listening to Dr. Diva Shah, what I understood that the role of the radiologist is like a tongue. I mean, the moment you want to eat something, you will come to know whether it is hot or cold, spicy, sweet, or whatever. And that's what the role of radiologist in the first place. Number two, their analytical skill, is commendable. Of late, we are listening, reading a lot about AI, but let's not forget that the role of a radiologist is absolutely based on HI, that is human intelligence. Because here, whatever they are analyzing, whatever they are putting it forward as a report. And let's not forget, these are a written report. These are not oral report that one can change. Like, okay, I have not said this or I have said that, and you misunderstood. So their responsibility,
Def-
their responsibility is like a Himalaya. I mean, they cannot change anything. Number one, on top of that, based on their reporting, their analysis, the cancer surgeon or medical oncologist, radiation oncologist, and clinical oncologist, they are deciding further treatment protocols. So, on an average, where we are having an impression that, okay, we have been given second life, third life, fourth life by cancer surgeon or radiation oncologist. Let's not forget that radiologist is playing incredibly pivotal role in diagnosing the cancer and extending life to zero whoever is diagnosed with
Definitely.
the cancer, and therefore I decided to bring in Dr. Diva to share her knowledge, experience, and I must admit that she had given presentation in a very, very, very meticulous manner, and I am grateful to you. On the other hand, one more point, we at Indian Cancer Society, and through this Fridays with the Shrenik session, we are bringing the specialists for simple reason that information what she has shared, or the information or knowledge what other specialists is sharing. You know, this information cannot be made available during one-to-one consultation because they are occupied with too many things. They have a lot of priorities. So therefore, we are bringing in such specialties. Uh, Vaishali, let's open the room for Q&A.
Sir, we have a question from chat box in Zoom from Dr. Priya Parmar. What is palliative radiotherapy?
So basically, palliative radiotherapy is given in an advanced cancer patient, and when he or she is suffering from significant pain at particular site, and then but see, let me tell you first that there is a difference between a radiologist and a radiotherapist. So first, you have to understand the difference between these two. Radiologists are the diagnostic people. they cannot treat the patients directly. So it's a basically job of a radiation oncologist, which is a different. They give a radiation to the particular tumor and the guide as per the guideline. So palliative radiotherapy is the answer can be better given by the radiation oncologist, not by radiologist.
Okay, ma'am. And there is another question from her, that what are the potential side effects of this therapy? Uh, but as you said, chemo.
Radiation oncologist can give a better answer and the right answer for this question. So again, I would like to redefine that radiologist and radiation oncologist. Many a time it gets mistaken that, but they both are a different subspecialty of oncology. Radiation therapists are the treating physician that treat the tumors with radiotherapy, while radiologist, the main work of a radiologist is to diagnose the various kind of cancers. So this is the difference that we have to understand.
Dr. Diva and Dr. Priya, you will get the answer to this specific questions on next Friday. We will be having a radiation oncologist already planned on next Friday. So, do join us and feel free to ask questions.
I think Sir Priya ma'am has got her answer, that she will join next session.
Okay.
Sir, and ma'am, there is another question from Preeti Khanna. She said, does PET scan has any effects on the body in terms of hair loss, etc.?
No, there is no such side effect of hair loss with PET CT scan. It's a myth. There is no side effect. It's not like chemotherapy. It's there is no side effect like hair loss or any such side effect which happens with the chemotherapy, certain chemotherapeutic agent.
She said thanks.
Yeah, welcome.
Sir, and there is no more questions in the YouTube currently. So if you have any questions, so आप start कीजिए. नहीं तो if our audience have anything, so please unmute yourself and ask.
Dr. Diva, for the sake of knowledge and information, I would ask one simple question. Particularly in the field of oncology or cancer diagnosis, how many reports, or rather how many reports you are analyzing in a day? That's number one. And number two, usually how long it takes to analyze the complete one, be it MRI, CT scan, PET scan, or USG.
Okay, so that's a very good question. First of all, how much time we take, it depends on which modality I'm reading. So, for example, if I'm doing a sonography of a small part, breast or a thyroid, which is a small procedure, so it takes not hardly more than 10 to 15 minutes. But if I'm reading a scan where I have to stage the tumor, I have to compare with the previous, then it may take more time, maybe 20 to 25 minutes. So this is how in a day depends on what kind of study we are taking. So but on an average we do like at least 15 scans we read. 15 scans we can read. We can stage or restage the tumor as per the need. And it's not just about staging or restaging of tumor. The patients who are on cancer therapy, they develop a lot of different kind of sequelae or side effects. For example, patient comes with severe abdominal pain, patient has colitis, patient may develop thrombosis at times. There are certain pneumonia which happens with the immunotherapy. So all this sequelae or the complications of the chemotherapy, that also we need to take care. We need to timely tell the medical oncologist that is there any infection or is there any inflammation which is happening into the colon, lung. So all these factors also we have to take care of.
Thank you. Thank you.
Yes, I think there is one question from sir. Yes.
स- दीपक सर, आप अनम्यूट कर लीजिए एंड यू कैन आस्क क्वेश्चन.
Why the mammogram is after the 40 years? Why not before that? For the reason.
Yes. So as such, it has a very soft radiation. So there are no
Okay.
radiation hazards. So if a
Mhm.
person, if a patient has a choice, she is willing to undergo mammogram, she can go. But that's why there is a specific guideline which has been given. If she is high risk female, she should undergo at the age of 30. But if she has no such risk, then definitely she can start at the age of 40. So that's the guideline which has been given by American Cancer Society, and that we follow to have a better, to avoid the confusion, that this is the guideline, but it's a choice. And there are no evidence now that the radiation which happens with the mammogram, that has any hazards. There are no evidences, there are no literature in the medical literature. So she can undergo, but overall at the age of 40 for average, and between 30 to 40 for the high risk. But if any female has any symptoms, for example, she has lump, then she can always undergo even at the age below the age of 30 also.
Recently, one patient came to us, is
Mhm.
only 22 years old.
Yes, yes,
And
yes.
she- In the US, and they
So we
denied
are
to do the mammography. Then we
okay.
done the MRI. In the MRI, they confirm. Then we do the PET scan.
Okay, okay. So, that is what I am telling you, that if a clinician is suspecting breast cancer or the lump which is highly suspicious, then she should undergo mammogram irrespective of the age.
Okay,
Yeah.
thanks.
Even in the pregnancy also, for the first trimester, we can avoid mammogram. But for the post second trimester, but since the availability of the MRI and ultrasound is well, so she can undergo MRI and ultrasound in pregnancy, because pregnancy associated cancers are common. It happens in the breast also. So for such reason, she can go MRI, but otherwise any female should undergo if there is a high and strong suspicion. If there is no suspicion, then we have to stick to the guidelines.
Dr. Diva, can I?
As per the ESCO, they ask only after the 40.
I'd like to ask you something.
Sure, ma'am.
We keep going back to the American Cancer Society for guidelines. Are there any Indian guidelines? Because to my knowledge, women present with breast cancer in particular 10 years before the white Caucasian group.
As such, even the Indian Cancer Society, they follow also the same guideline.
I know, that's what I'm very happy
Yes.
about it, which is why I'm asking.
Yes.
Because I think that if you all as doctors can get together and
Yes.
give us the guidelines, because we are not medical people.
Hmm.
We have some doctors on our books, but they're not all medical people. So people like you who are seeing this day after day, you
Correct.
know that women come in earlier. The gentleman before me just said at 22. Yes, we've seen that.
Correct.
Yeah. So
Agreed.
what do we tell them? I mean, it's no use producing American guidelines to them.
Agreed. Totally agreed that we should have our own evidences of breast cancer happening between 20 to 40. And with this evidence, definitely we can push this to have our own guidelines, and which really help. Because, yes, as Sir has also asked, there is a myth that below 40, a woman should not undergo a mammogram, which should not be the criteria.
So
I
for us in the Indian Cancer Society, we recommend self-breast examination,
Yes.
clinical breast examination once a year, and mammography only with the advice of a doctor, a gynecologist.
Yes,
So
yes.
they avoid the unnecessary radiation. I don't know if that is,
No, that's not, that is what, like, if we go with the medical literature and if we go, there is no evidence that mammography radiation causes any immediate or later side effects. That's now been very clear. And with the advent of a new technical machines, the information is quite more, and the radiation hazards is nil. I can say nil, apart from the first trimester of the pregnancy.
That's reassuring, but also a lot of women worry about the cost of mammography.
Agreed. But it's been now, with cost is higher for the advanced technique like tomosynthesis, but for the screening mammogram, it can be, we can have some consensus, but definitely the point which you have raised, I agree with that. That the cost is also a one factor which
Definitely. Yeah.
agree. In an Indian scenario, definitely it's a very important factor. I can say that.
I hope
Can I
you
ask one
all
more
get
question?
together and make an Indian guidelines.
Yes.
Huh?
Please.
Thank you.
Thank you,
Can I
ma'am.
ask one more question?
Yes, sir, please.
Why in India not the thermal imaging is there
Uh,
compared to in USA thermal imaging is there?
yes. So,
And another thing is that why we are following only America, not ESMO.
that I agree for this. Thermal imaging, to my experience, frankly, I don't have much experience. And second thing, we as a breast radiology society, we do not recommend thermal imaging because it's not a standardized imaging procedure. There are lots of loopholes in this thermal imaging. There are lots of false positive. It's not being approved and recommended by any society. uh, Breast uh, imaging society, Indian Society of Breast Cancer and Imaging, it's a very large society, and they have really not approved this thermal imaging. And even as a radiologist, I would not approve this thermal imaging for the analysis and evaluation of the breast diagnosis, any cancers, breast tumors. So I would not recommend this.
I ask the second question, why we are not following ESMO?
Yes, that's something which really a burning question. Maybe I'm not the right person to answer right now at present. There are lots of controversies between ESMO and American society, and it should be a common consensus by Indian Cancer Society to follow, which, I mean, it's not just American society, it's American society, it's ESMO, it's NCCN. So it's between a lot of fights, and sometimes, we get confused what to follow and what not to follow.
Yeah.
Cancer types.
So we have to make a new society, Indian society for the
Don't
legal oncology.
don't make a new society. Just make Indian guidelines. If
Yes.
all of
Yes,
you
that is the
people can
most requirement now. That is
yeah,
the most requirement.
yeah.
True. Very true. I totally agree with this viewpoint that we should have our own guidelines, because the cancer type, cancer scenario varies from this continent to continent, and the developing state, the practices differs. So if we have our own guideline, it will be definitely beneficial to our patient rather than following the Western guideline in each and every step.
Yeah.
Definitely.
Same question I have raised in the Tata hospital. Why we are not doing this?
Burning question. There's one more question or discussion from ma'am, I think.
Yeah.
Yeah,
Hello, ma'am.
please.
Hello, Dr. Diva. I want to ask one question. I have recently undergone a lumpectomy, and
Okay.
my radiation is going to start on Monday. But
Okay.
when my PET scan was done, there was a nodule in lung also.
Okay.
which doctor said it is just nothing, don't worry about it. So
Correct.
do I need to worry about it at later stage, or do I need to follow it up?
No, you just need to follow it up. See, that is what, like lung cancer screening, when we do, or any cancer screening, we see lot of such kind of nodules in the lung. It can be normal small granuloma also. So we see the characteristic of that nodule. We see whether there is a avidity or not in that nodule. And on that basis, we decide. So in your case, I would say the nodule, what is the size of the nodule, madam?
They didn't go all that way to check what the size or everything.
Okay.
In PET scan, it was showing a small nodule, which doctors, my breast cancer oncologist, they said it's nothing. Don't worry about it. We'll see after 6 months when we get the PET scan done.
Yes,
Then
ma'am.
we'll see.
So I think you just have to, vigilant about that next PET scan. You make it sure you talk to the radiologist that I had a nodule in my previous scan. So see it thoroughly. We usually compare the nodules. When there are many nodules which we see benign nodules. It can be tuberculoma, granuloma, some soft tissue nodule, and they are benign. So you don't need to worry when it is less than. And for the 6 millimeter nodule, we can't do anything also further if it is
Okay.
really not avid. So we can just do follow up of that scan. And it's not necessary every time you do a PET scan for that nodule. You can do just a simple CT scan, not the chest X-ray.
Okay. Thank you.
Thank you, ma'am.
One last question from me, please.
Sure, ma'am.
Young women quite often have um, knobbly breasts, what feels like a gant in the breast. So, what does one do? You can reassure them. Is that all? Or should one be doing anything more than that?
Yes, so as a clinician, see, with the experience, of course, you can reassure. But the next most important thing which we can offer to her is just to get an sonography done from an experienced radiologist. Because this gland, sometimes they always they when we tell them, and as an educated patient, you do self examination of the breast, or you do, so they feel yes, there's some lump or something. And nowadays with there are lots of females, young female, they get the PCOS. There are a lot of hormonal imbalance with the kind of food habits and their lifestyle, and then they feel a lot of heaviness in the breast because of this hormonal imbalance, and this leads to lumpish filling in the breast, pain in the breast. And in that, the reassurance is of course one way, but other apart from it, the role of radiologist really helps, where we can offer them a sonography, which is an easy solution.
Okay, thank you.
Thank you so much, ma'am. Thank you.
Dr. Diva and Jasnaji, I'm coming back to the cost factor of mammography. I believe that undergoing mammography is imperative for simple reason that you can get diagnosed when in time, your life can be saved. Treatment can be managed well in advance because yes, that is a cost, but at the same time, if you make a graph of the cost of mammography against the precious life of the human or a female, there is a remarkable difference. So, one has to take a due consideration to call of saving their own life as it is spending money for mammography.
Definitely.
We do that, Shrenik bhai. We give mammography at our screening center at, peanuts.
Peanuts.
But we cannot tell the commercial
Yes.
centers what to charge.
Then I agree that just that it's certain factors outside that these are not within our control, and we need to manage somehow or the other. And yes, I mean patients or survivors are being victimized, but then we need to manage as against saving the precious life. That is all I believe. Actually, if there is no further question, then we can wrap up the today's session.
Yes, sir, we can wrap up now.
So much, so much. So, Dr. Diva, madam, thank you so very much. I am deeply grateful for all your time. Great to, listening you and sharing all information with these slides in a very, very, easily understandable arrangement situation. And we look forward to inviting you once again for a period of time. And
Thank
friends, let me add one more thing that the husband of Dr. Diva Shah, Dr. Siddharth Shah, is a eminent head and neck cancer surgeon, and again is a dear friend of mine for more than 10 years. So, madam, do convey my warm regards to Dr. Siddharth Shah, and thank you so very much for your valued time and being on our show. And friends,
you.
next Friday we will be having a radiation oncologist. So do join us and feel free to ask questions. Thank you once again, madam.
Thank you so much, ICRI team and Shrenik Bhai, for this opportunity. Over them, and thank you, and hope to meet you again with some specific topic.
Sure.
Absolutely.
Thank you. Thank you so much.
Bye.